Welcome to today's webinar. My name is Elia Hopkins. I'm the Director of Community Engagement in Southeast Minnesota for the Mayo Clinic Health System. On behalf of our team, welcome to today's webinar. At Mayo Clinic, we understand the intersection of healthy communities and strong economies. Today's speaker, Dr. Stacey Rizza, discussed this at the Minnesota Chamber of Commerce Executives meeting earlier this year. We received a number of requests for Dr. Rizza following that, so we're glad to partner with chambers from across our region and throughout Minnesota to bring you today's program. We will hear updates on COVID-19 and provide you with useful information to keep your employees and customers safe and healthy. Feel free to use the chat feature to share where you're watching from today. Dr. Rizza will share some of her thoughts, and then we will take your questions. We'll also share some websites at the end where you can get ongoing information from Mayo Clinic. Before I introduce Dr. Rizza, let me just share a little bit about Mayo Clinic. Mayo Clinic is a nonprofit organization committed to innovation in clinical practice, education, and research, and committed to providing compassion, expertise, and answers to everyone who needs healing. We have practices in Florida, Arizona, and Rochester, Minnesota. And the Mayo Clinic Health System consists of clinics, hospitals, and other facilities that serve healthcare needs of people in Iowa, Minnesota, and Wisconsin. The community-based providers, paired with the resources and expertise of Mayo Clinic, enable patients in the region to receive the highest quality physical and virtual healthcare close to home. And this integrated system has proved particularly important to care for our patients and our communities during this pandemic. And now, what you're all here for, let me introduce Dr. Rizza. Dr. Stacey Rizza is an infectious disease physician. She's been involved in laboratory-based research, clinical research, educational initiatives, and has maintained a busy clinical practice. That is a full plate for sure. Among other roles, she's professor of medicine and the previous chair of the Mayo HIV Clinic. In addition to her full bio, which you can see on the slide, since the early days of the pandemic, Dr. Rizza has been sought out for her expertise in infectious diseases and COVID-19. She's consulted with Delta Airlines, Hilton Hotels, McDonald's, and other institutions on the best ways to manage the pandemic for these major employers and organizations. And most recently, in fact, just earlier this week, she was named the Executive Medical Director for Clinical Practice International, where she will work to advance Mayo Clinic's mission and strategy by fostering the development and integration of the international clinical practice and provide consistent and high-value care. So again, as a reminder for those who have just signed on, we are recording this session. Please use the chat feature to let us know where you're signing in from, and use the Q&A feature to post your questions and upvote to questions that are of interest to you during the presentation. Thank you all for joining us, and now, thanks to Dr. Rizza for being here, we will hear from her.
Well, thank you so much for that introduction, and thank you for inviting me to be back. I think this is just a really fun forum. In fact, I've enjoyed watching the comments on the side of where everybody is logging in from, and I feel like I'm very connected with my fellow Minnesotans right now. So COVID-19, or the virus SARS-CoV-2 that causes the syndrome COVID-19, as I'm sure you are all aware, is an extremely diverse topic. And we can get into all sorts of different issues, from the politics, the science, the epidemiology, the social implications. But for the purpose of the next 15 to 20 minutes, I'm going to give a very high level, 30,000 foot view of a few topics in particular, just to give kind of a groundwork of where we are now and our understanding of the viruses. And then want to leave plenty of time for everybody to ask questions, which I will attempt to answer or will address in one way or another, because many of the issues people have or the questions they have are very nuanced and very particular to your own situations that I may not cover completely in the talk. So I want to leave plenty of time for those questions and answers at the end. So SARS-CoV-2, as I'm sure everybody knows, is a virus. And it's a virus that is transmitted predominantly through what we call droplets. Not exclusively, there are a few rare situations where it could be different, but predominantly it's a droplet-mediated infection. And what that means is if somebody's infected, like let's say right now I'm infected with SARS-CoV-2, If I cough or I sneeze or I sing or I speak in a particularly animated way and I'm spitting a little bit or anything that makes me expirate, I can expel little teeny droplets that can fly through the air and are heavy enough that they usually only make it about 5 to 6 feet. And that's why you'll hear the magic number of 6 feet that we all have to stand apart in public. And once they've gone that distance, in a matter of seconds or minutes, they will either land on somebody else or they'll just fall into whatever surface happens to be below them. So when you think about that, that can explain many of the measures we're doing for protection and how people get infected. So the main way people get infected is they are standing close enough within 6 feet of other people, and they're not wearing masks or not taking other precautionary measures, and somebody either coughs or sneezes or speaks or something so that a droplet would land on them, and then it gets into their mucosal membranes and they can become infected. Now, the other way is, let's say I'm infected and I sneeze on my desk, and then I get up and walk away, and somebody else sits down right after me, touches the desk, and then wipes their nose or drinks coffee and touches their lip, or somehow self inoculates. That's another way that people can get infected. So, with all of that in mind, the approach we take to preventing transmission is what I like to refer to as the belt and suspenders. So, it's a many layers of protection. Now, the first layer of protection is wearing a mask anytime somebody is in public in a communal place, and particularly in a indoor communal place. So what that means is if you're out for a jog by yourself, you don't need a mask. If you're out walking your dog by yourself, you don't need a mask. But if you go into a bank or into a McDonald's or into any kind of indoor facility like a grocery store, everybody needs to be wearing a mask at that time. The way the mask works is if I am wearing a mask and I happen to be at the grocery store and I speak or I cough or I sing or I do anything or sneeze, it's going to get trapped in my mask and it's not going to accidentally hit another person or land upon a surface. Now, as a second layer of protection is the recommendation to do the 6 feet apart, or what we call social distancing. I prefer the term physical distancing because that's actually more accurate. We're not trying to socially distance people, we're just trying to physically distance people. So if I'm at Hy-Vee or I'm at a grocery store and somebody coughs or sneezes and they have their mask on, that's great. A little bit may get out, not go very far. But if I'm also more than 6 feet away from that person, it's extremely unlikely that that droplet can fly that far and hit me. Now, the other layer of protection is the disinfecting of high touch surfaces. So if you disinfect several times a day, and at least twice a day is what we recommend, others more often, any place that people touch often in these public places. So the doorknob, the sink faucets, the escalator handrails, countertops or tabletops, any place where there are a lot of hands, if those are being cleaned regularly, then we know that it's less likely that those viruses or those droplets can stay around and lead to other people getting infected. Now, if you take it even one step further, and let's say I'm wearing my mask and I sit down at a countertop that unfortunately hasn't been disinfected, so I touch a little bit of virus without knowing it. As long as I clean my hands before I take the mask off, before I eat, before I drink, before I touch my face, and my hands are clean, then I'm also not going to inoculate myself. So the 4 layers of protection are in communal spaces wearing a mask, socially distancing or physically distancing, which I prefer to call it. So we're standing far enough apart that we can't expirate droplets on each other. Disinfecting those surfaces, so even if by chance something gets there, you wipe it up, it's not there anymore. And then very importantly is good hand sanitation, cleaning hands before taking your mask off or touching or eating or drinking. If I touch a contaminated surface and I still have my mask on and I can't wipe my nose, or if I wipe my nose, it's not going to inoculate because the mask is there. So all of these layers of protection are what is going to help us prevent transmission slow down the rate of infection, and help us get through this much faster. If everybody on planet Earth did these four things all the time, we would be through this very quickly. The reason why we're not is that there's a low level of positivity that continues to percolate because this isn't happening in all places and people are still transmitting and getting infected. Now, the other thing to remember is the kind of mask and how it's worn. And this is where I'm going to get really nerdy and ID and sort of nitpicky because it does make a difference. We recommend any mask that you can't see through. So if it's a mesh mask or such a thin little mask that you can easily see through it, then it's probably not going to work. If it has a big valve in it, it's not going to work. It needs to be a thick enough cotton in a completely closed area that you can't see through it in order for it to be strong enough to control any of these droplets. And then it's really important that it's over your nose and over your chin from your mouth. So there's so many ways that we see these being misworn. And what I recommend is it shouldn't be around your neck because then it's going to tent over your nose and you're not going to have a complete seal. It should be up either around your ears or on the top of your head and completely seal over your nose and around your mouth. And that's unfortunately, it's not always the most fun. It's not always the most comfortable, but doing it well now is how we're going to all get through this sooner. So it's just sort of sucking it up for a little while so we can be done quickly. Now, we have learned a lot more about this disease and this virus in the last 9 months, fortunately. We've learned what it does to the body, where it affects the body, and who is going to have a better indication of who's going to get sick in some situations. Now, for many people who get this infection, they'll have virtually no symptoms at all. Some will have extremely minor symptoms. Some people will get fevers, chills, and cough and body aches and feel like they have the flu. And some people, which is the whole problem, will get critically ill and could even die if they don't have adequate medical care quickly enough. And we are getting slightly better at predicting who are the people that are going to be fine and be asymptomatic versus who's going to get critically ill. We're certainly nowhere near perfect or adequate, but we at least have some hints. There are a few genetic factors, and undoubtedly we'll learn more. And what the implications are of those genetic factors, we have to figure out. But there are also some environmental factors, healthcare factors that we know make people more likely to do really poorly versus do okay. And those include things like underlying heart disease or high blood pressure, underlying lung disease, underlying kidney disease. But one of the most powerful risk factors that we're learning all through the time it was in Asia, we're seeing it from all the studies in Europe and repeatedly in the studies in North America, is obesity. That having a BMI over 30 because of being obese and not just from muscle mass is making people more vulnerable to ending up with a poor outcome and needing to be on a ventilator or needing critical care support. And if you're interested during the question and answer center, we can get into that a little more. The original focus on being immune suppressed has not really played out that well. Now, if somebody's under active treatment for cancer, yes, they are at risk of doing poorly. But there are quite a few studies that have looked at people who are on other kinds of immunosuppressants, like people with MS who are even getting biologic treatments. And the immunosuppression actually didn't make that big of a difference, whether they did poorly or did well. In fact, in those studies, what made the difference was their obesity, not whether or not they were on immunosuppressants, and whether or not they're elderly. And we're learning that the effects of being elderly are likely not due to the immunosuppression, but they're likely due to what we call immune dysregulation. Meaning that it's not that the immune system's weak, it's that the immune system's kind of messed up as you get older, and people tend to overreact to things like viruses, and their bodies have an overreaction and cause this inflammatory storm that makes them more likely to do poorly. Now, fortunately, we have more therapeutics available than we did back in February and March. And the most common one you'll hear about, and the one that actually has pretty much the only one that truly has proven efficacy right now, is the drug called remdesivir, which is a drug that was by Gilead. It's an antiviral drug. It already has EUA approval, and it's gone through all of the rigorous testing that needs to happen to prove that the drug is actually efficacious and works. Now, there are many, many other drugs that are in the pipeline and are in clinical trials right now. Many of them are antiviral medicines that many times will be added to remdesivir, because we know in most cases for viruses, two is better than one. Others are standalone, but we'll see. And then the other class of drugs that are being tested are the immune modulators, are essentially, as I mentioned, having an overreactive immune system that overreacts to the virus seems to be what causes people to become critically ill versus just asymptomatic or mildly ill. And we're getting much better at understanding exactly what parts of the immune system are over triggering or are messed up during SARS-CoV-2, and using drugs that can particularly target that teeny little area. And so many of those drugs are in clinical trials now. So we're not where we want to be, that we have drugs for everybody that perfectly treat it, but we're much better off than we were 9 months ago and have many other drugs in the pipeline that should be coming forward. Now, the other thing people ask about frequently, and it's what we all want, but I think it's worth talking about what we actually have and where the science is, are vaccines. So what we want is a vaccine that prevents infection, meaning we give a vaccine to somebody who's never had SARS-CoV-2 and it prevents them from getting the infection. That is what we call a preventive vaccine. And in order to get that, what you need is to induce protective immunity, meaning I give somebody a shot or a protein or something, and their body forms an immune system response to it that prevents that person from getting infected. They have protective immunity. So if we take a step back and look at what are the categories, or how do viruses usually respond to vaccines, I like to group viruses into three big buckets or three big categories. The first category are the polios, the measles, the mumps, rubella, that the vaccines are outstanding. They work extremely well at preventing infection. If every human on planet Earth had those vaccines, they would be gone from existence. That is the first category. The second bucket, or the second category, are the influenza vaccines. The ones that are okay, they're pretty good. They're probably around 60% efficacious. They prevent deaths. They make people a little less sick with it. They're not perfect, but they make a difference in society. You have to keep revaccinating because the effect wears off. So it does something, but they're not perfect. Then the last category, or the third bucket, which quite honestly is the vast majority of viruses that infect humans, despite billions and billions of dollars of research, absolutely outstanding science, and decades of work, you simply cannot form a vaccine to that virus that prevents infection. And that's the vast majority of viruses. That's the CMV, the EBV, the HSV, the HIV, the hepatitis C, and I could go on for a while. We still don't know which bucket this virus is going to fall into. We hope it's bucket one. If not, we're hoping bucket two, and we sure hope it's not bucket three. But quite frankly, we don't know yet. In order to figure out if a vaccine works, there are a few phases that have to happen. And right now, there are over 138 vaccines that are in some phase of a trial, and probably over 40 that are already in human clinical trials. But what they need to do is they need to first go into what we call phase 1 and phase 2 trials that look at what we consider safety and tolerability. Is it safe? Does it hurt people? Does it cause problems? And this is done and people have not been infected yet. And then once we know that it's safe and tolerated, then it goes into what's called a phase 3 trial. And what that means is you take tens of thousands of people and you randomize them to either get placebo, so a shot of nothing, or a shot of the active agent, and it's blinded, meaning nobody knows which one they get. And that's called a phase 3 placebo-controlled randomized trial for efficacy. And then you wait a long time, months, sometimes years, and just see if the ones who had the active shot are less likely to get the infection than the ones who had the placebo shot. And that's what you need to do to completion to know whether or not the vaccine actually works. Now, what you'll see in the news is a bunch of vaccine companies have published that our vaccine is safe and tolerable, great, and that it induces an immune response. Quite frankly, that doesn't impress me. That's a very low bar. Almost any protein you put into a human, you could shoot cardboard into my veins and I will form an immune response to it. That's what humans do. That does not mean it's a preventive immune response and capable of preventing the infection. An example would be HIV. When somebody gets HIV, they form an immune response. They have antibodies to it. In fact, that's how we test for HIV is we look for those antibodies. But we know very well that if somebody has antibodies to HIV, they could still get reinfected with a new strain. It's not a preventive immune response. And that's what we're looking for is a vaccine that causes a preventive immune response. So unfortunately, there's been a lot of politics that have gotten into this because everybody wants it. Everybody would love to have a very highly efficacious preventive vaccine available for the whole world. So, will there be a vaccine approved by the end of the year or early next year? Maybe. In fact, probably because politics is getting in the way. Will it be proven to be efficacious? I'm still waiting to see. What's happened in other parts of the world is there actually are two vaccines that are already approved. One of them is in China and one of them is in Russia. And they were both shown to be safe and tolerable. Neither of them has been proven through placebo controlled trials to be efficacious yet. They are both homebrewed in their own country, and their regulatory boards said, yep, it's safe, it's tolerable, should work, let's just approve it. That's never happened in history. Usually you have to prove it works. They skip that step. There is a chance we will approve something, but whether it actually has high levels of proven efficacy, we have to wait and see. I'm hoping they will, but we have to wait for those trials to end. And then what we also will need time to tell is how long does it last? We know that people who get SARS-CoV-2 now can get reinfected. The first case that was described was somebody who was infected in China and 4.5 months later was infected in Spain. And they actually did the sequencing of the virus and proved that it was a new, fresh virus. It wasn't just the same one recreating in the person's body. And I can tell you that there are a number of other cases that are about to be published and reported after that, where they're all proving that it is a new strain. The shortest time period I have seen is 10 weeks from the first infection to the next. So, what that tells us is even if somebody gets infected and develops a protective immunity, after a few weeks to months, it wears off and they can get reinfected. So, if we have a vaccine that works for 10 weeks, it might make a difference. Whether it's going to change the world and we could go back to the way we were, I think we're not quite there yet. And there is a good chance that there'll be vaccines that come out early that will get approved because we have nothing right now. So anything that shows efficacy is better than nothing. But over time, we're likely to get better and better ones because really smart science took a little bit longer. And those are going into trials now, quite frankly. And they will take months to years to finish the trial, to prove efficacy, to get through the approval process. So there's a chance we could get early vaccines that we all get vaccinated for. And then if new ones that are better come along, we get boosted again with new vaccines in the future. So the last thing I will finish my portion with, because I don't want to speak the whole time, I want to leave plenty of time for questions, is what can we do in society? What can you do in your businesses? How can we get people back working and living with COVID rather than just hiding from it? And it comes down to those four modes of transmission. Having your employees and your clients and your public indoors wearing masks all the time. Having high touch items and areas disinfected regularly. Assuring social distancing however possible, meaning you have people maybe stepping through lines at more distance apace, employees working in a space that they're never close together for less than 6 feet for more than 5 minutes, so they're able to move around and not be close together for prolonged periods of time. And then advocating strong hand washing, having hand dispensers all over the place for people to use, and really encouraging people not to come into your facilities and employees not to come to work if they're sick in any way. It's going to be a pain in the neck. You're going to have backup employees. You're going to have systems for people to call in that morning, because frequently it's when you wake up in the morning that you realize, oh, I don't feel so well. I have a sore throat and a fever and I'm achy. It's going to take a lot of planning to accommodate that. And we're asking for people to do it in ways they've never done before. But it's really important that we do that to prevent transmission in these public places. So I will finish my formal discussion now so we can have plenty of time for interactive discussions for the rest of the session.
Excellent. Thank you for hitting on some high points. And for those of you who have joined after we got started, you're welcome to let us know you're here. If you want to share where you're calling or signing in from, please use the chat. But we will use the Q&A feature for questions, and you're able to upvote. So if you see a question that's of interest to you, just click the little thumbs up and it will help the question rise to the top. Our first question is, why does the current guidance state that if a person has a negative test result, they should still stay home for 14 days?
So if you could clarify for me which guidance, because that is not CDC guidance. CDC guidance, what the federal government would recommend, the CDC guidance, is if somebody has symptoms, then they should go home and be tested. If they're positive, well, there are two things you can do. You could stay home for 14 days, or you could be tested. If you're positive, it recommends staying home for at least 10 days from the positive test and at least 24 hours from your last symptom. If you're negative, then you're supposed to wait at least 24 hours from your last symptom, meaning don't come back to work even if you're sick but it's negative. Still wait till your symptoms are over for at least 24 hours. But then you could leave your house and go back to your normal public behaviors in the COVID era. And so that is a federal recommendation that most other organizations advocate.
Great. Yeah, I think there in this evolution of the few months that we've been dealing with this, there's been so much iteration of some of these guidelines that sometimes it's hard to stay current with what's the most recent thing.
Absolutely, and that is one that's changed relatively recently.
Okay, how about, you sort of touched on this, but here's the question. Any guidelines on having antibodies, let's see, and how long they last? What is the benchmark to indicate if you had recently had COVID and didn't know it? Titer is the question.
So I'm going to spend a little bit of time defining the antibodies and what we're talking about. So antibodies that we use to test people are called immunodominant antibody, meaning if you had the infection, almost 100% of the time, that's the antibody you'll form. Meaning, let's say this is the virus and this is your antibody. Let's say it's right here. That this one almost is reliable, that if you had the infection, at least after 14 days or a little longer, your body will create an antibody to that spot and we could test you and it says, yep, you had the virus. That is an immunodominant antibody. That is in no way suggestive of a protective antibody. And the protective antibody is the one I was discussing earlier on. That means it prevents you from getting the infection, or it's able to grab the virus and optimize it and sort of clear it even in a test tube. Some early data out of China suggested that, and it's not perfect, and it's early data, we certainly will learn more, is around 7 out of 10 people who get the infection and have the immunodominant antibody, meaning, yep, they had it, will develop these protective antibodies. But we also have data out of Italy that says those tend to go away, the protective antibodies, after a few months. So even if you had it, that's what makes people a little nervous about the vaccine, they tend to go away pretty quickly. Now, the immunodominant antibody, the one we're looking at for the SARS-CoV-2 infection, so far seems to hang around. But remember, we haven't even known about this virus for a year yet. So everything we're saying is with a big asterisk of who knows, time will tell. But so far, the one that's looking at whether or not, yes, you had it or no, you didn't, and it's a good test, it's well over 97% sensitive and specific, is an antibody that seems to stick around. So if you wait at least a few weeks or a month or so after you had the infection and you do that test, it's a pretty reliable test. And Titers so far have not been meaningful. It's positive, intermediate, or negative. Negative means negative, positive means positive, but we've had a bunch of people fall into the intermediate section. And what that likely means, we don't know for sure, but the majority of people who are in intermediate tend to not progress to positive. What you can do is test a month or so later, but the vast majority of them don't progress. What it probably meant is at some point in their life, they had another human coronavirus as a cold or something else, and they have a little cross reactivity. But a positive is meaningful and a negative is meaningful.
Next question, with flu season upon us, symptoms are going to run rampant. How does a person know whether to simply stay home or to go get tested for COVID?
Great question. I think flu is a very important thing to think about. We're encouraging symptomatic people go home until you get tested, but we are encouraging people to get tested and then stay home until you have your results. And even if you have flu, you stay home to your at least 24 hours symptom free. Or if it's SARS-CoV-2, it's 10 days or 24 hours to your symptom free. Now, I think that brings up another good point I just want to highlight is that it is going to be essential this year more so than ever that everybody gets their flu shot. And it's for two reasons. Firstly, to help get rid of that complication of flu going around. We do know that many of the measures that we're asking people to do to decrease the risk of transmission for SARS-CoV-2 also decrease the risk of transmission for flu. In fact, Australia in the southern hemisphere is just getting out of their winter, and they had the lowest flu numbers they have had in decades. In fact, they had astronomically low flu numbers because social distancing and masking and cleaning and hand washing, you're not transmitting flu either. And that's encouraging. But it's essential people get their flu shot to help decrease it even further. But for another reason that we've just learned about. We've known a long time about this phenomenon called immune training. But there's good data now. In fact, we published it out of Mayo in collaboration with the group, an AI group through MIT and in Cambridge, that any vaccination, including flu vaccination, revs up the immune system such that you're better able to prevent yourself from getting infected with SARS-CoV-2, or you're more likely to have a mild case. So the analogy is think of the immune system like a muscle. If you exercise it, it gets stronger and works better. It's not that the flu vaccine overlaps with SARS or anything and you get cross-protective immunity. It's not. That's been shown. They're not even close. But any vaccination, whether it's your shingles vaccine, your pneumovax, your flu shot, whatever you're up for, go get every vaccine you could possibly get right now and encourage your employees and your families and your friends. And we know that that is going to decrease your chance of getting SARS-CoV-2. The first hints of this we saw actually months ago as it was moving through Europe. It was very interesting why some countries were getting hit much harder than other countries, or some populations were getting hit harder than others. And it many ways tracked vaccination levels, particularly MMR levels. In fact, there's this whole theory like, hey, does an MMR vaccine actually cross-react and help? And it doesn't. But one of the countries, the best example is Germany, actually had very low numbers of deaths and ICU admissions and transmissions. Germany is an outstanding country for vaccination. They have a very high vaccine level, particularly their MMR population, which is a certain group of elderly individuals who they needed to make a concerted effort that they got that vaccine, which came out later. Italy has terrible vaccine levels. In fact, their elderly have the lowest MMR vaccination in the world. And Italy got slammed, particularly their elderly population. So it's not to say that's the only reason, but it has been tracking that highly vaccinated populations do better. And even when we did big data AI on tens of thousands of patients, it tracked almost perfectly that vaccination was a protective effect no matter what the vaccine was. So some people wait a little longer in the season to get flu shots than other times because flu shot does wane after about 4 or 5 months. In this season, we're saying don't wait. Go out there now in September and early October and get vaccinated because right now it's SARS that we're trying to worry about. Hopefully this will be a lesser flu year if everyone does all these measures and the vaccine will take you through.
Great, thank you. You've mentioned a number of times that we can get through this and suggested with proper adherence to mitigation measures and that it would shorten the time to accomplish this. Does this mean the virus dies off and loses potency, or does it mean we're just managing it long term, like influenza and other flu types we've experienced in Minnesota forever?
So in my opinion, no, again, nobody knows. This is a new virus, but in my opinion, it's B, the second option you said. I highly expect that 5 years from now, and maybe even 10 years from now, we will still have SARS-CoV-2 infections. The goal, when I say get through this, what I mean is drive the levels to be so low that there's a very, very small level of transmission, that we have the drugs and the ability to take care of the few people who are getting infected and manage them well. And it's like influenza, that we just have a approach to it and we live our lives in the face of it and despite it. Being careful during cold and flu season, you shouldn't go out if you're sick. You should wash your hands. You should get vaccinated because we do have a vaccine for flu. You should take all the same measures. And I think we will get to a situation like that with SARS-CoV-2. Mutating won't make it go away. In fact, it's already mutated a few times. And it's changed a few things. It's changed its infectivity in some regions. It's changed a little bit of the clinical course in others, but those are not the dominant strains that are circulating. It's still the wild type strain is the dominant strain that's circulating. And it is, do not expect this to mutate itself away. That's not, I don't think that's going to happen.
Okay, this is a bit of a follow-on to that, particularly since we're talking to a number of chambers who, typically get together for meetings and networking and things like that. Can you help provide some guidance on holding in-person meetings and business networking and things like that, assuming that adequate precautions are being taken? Is there a timeline that we should be thinking of, short-term, long-term, about these kinds of activities?
Great question. And I always start the answer to these type of questions with a little preamble, if you'll indulge me. Everything that we are talking about around SARS-CoV-2 is all around risk tolerance. I can't promise that anything is going to be risk-free. We can't. We can't I mean, we can tell you things that are high risk, but we can't promise anything is going to be risk-free. So the safest thing is to go hide in the woods and not see anybody. I mean, that's probably the only way I can say you're risk-free. Beyond that, it's all a matter of risk mitigation and risk tolerance. So with that as a preamble and a background to everything I'm going to say next, I think we are at a point, if you're in a city or a region that has less than 5% positivity, so that means things are going okay, that we could start to cautiously consider these type of things with all of the measures in place. And what that means is offer online options for those who choose to. That's the safer thing to do. If you choose to have an in-person meeting, it be in a situation that's ideally outside and, spaced out and well ventilated. We in Minnesota know better than anyone that that's going to eventually run out soon, and we're going to have to go inside. And then once you're inside, it be in an area that's well ventilated, good HVAC systems that are highly functioning and well ventilated, a large enough space that people can be socially or physically distanced at least 6 feet from each other. Everybody be masked the entire time you're indoors together. All the surfaces be disinfected before and after the meeting, hand washing before and after, and there's no drinking or eating or any reason why you should ever remove your mask. And the numbers of people in person be controlled. So it is rare you're going to have a room that you can actually do everything I talked about with more than 10 or 15 people at most in it. And many times what we've encouraged people to do and what we've seen many groups do is only have 5 or 6 people maybe in rooms with all those discussion points put into place, and then have a few others up on the screen through Zoom. So you're having kind of a hybrid meeting for those who feel more comfortable versus those who want to, take it slower. And what we've seen from other trends around the country is even in the colleges, like Temple most recently, that had this big outbreak, it's happening in the small social groups. It's happening at home in the apartments where they have 6 people over to watch a movie together. It's happening in the family birthday parties. We have everyone over on the weekend, or the picnics. If you put all those measures in place, it's not happening in the school cafeteria It's not happening in the classroom where they have everybody socially distanced, only 10 kids in the class, everyone wearing a mask. If those measures are thoroughly put in place and rigorously held to, that's what's controlling it. It's when we're seeing these transmissions, it's happening in the other situations where those measures are not being followed.
Great, thank you. And we've got a number of questions. And again, if you, for the viewers, if you go in and upvote for questions, they will pop up to the top. But there are a couple questions about how long the virus can transfer from surface to another person and how long the virus can last on a surface.
Good question. And the short answer is we don't quite know yet. Um, it depends on the surface itself. It depends on the humidity. It depends on the temperature. It depends on the inoculum. If it happened inside versus outside. Outside there's wind and sun and everything. So we don't know. Many of the studies are using what we call a surrogate. So they take a little droplet and spray it and see how long that lasts. But that's not necessarily a perfect reflection of what happens with the virus. Other studies are doing it with viruses, but not SARS-CoV-2, and that's nice and interesting and maybe helps us, but that's not perfect. What you need is to use the live virus, which is really hard to do and can only be done in a biosafety level 3 facility. Spray it as if somebody's speaking or talking or rubbing their nose. And then you look over time how long the virus is what we call replication competent. You can pick up little pieces of the virus for a long time, but whether that actually means it's an infectious virus is what we care about. And an infectious virus is what we call replication competent, meaning it's still capable of replicating and infecting other people. So those studies, the rigorous studies that are being accurately done, really aren't completely finished and verified, in my opinion. Earlier studies of indications suggest it could be anywhere from, you know, 20 minutes to a few hours, and in some situations maybe longer, but that's a tough situation. In others, if it's outside in the wind, on bark, in the sun, it may only be a few minutes. So it's really, it's not quite known yet. We do know that anything that's slick, it can stick around longer. If porcelain, laminated wood, metal, anything where droplets can kind of accumulate and sit, it can sit a little longer. And we know that even normal commercial cleaners, if cleaned and disinfected appropriately, kill it easily. It's not like this needs, 100% bleach to die. But it is the reason why we're still encouraging high touch areas to be disinfected on a fairly regular basis.
Great. You've talked a little bit about what employers can do inside their workplace for their employees, but we have a question here that's specific to do you recommend taking temperatures of visitors? But perhaps you can also talk a little bit about things you've recommended to other businesses that you've consulted with about how to manage customers. And another question sort of speaks to the issue of how to maintain your calm and not let emotions prevail when you're trying to talk with people about some of these issues, because there can be some, heated exchanges.
The great questions, and I'll leave the last one to the end because that one, of course, is the most challenging. It is you can control your employee behavior because that is, as employers, that is your right. You can ask them to take their temperature before they come in. You can ask them to use an app to tell you if they're feeling sick or having any symptoms. You can, ask them to wash their hands and wear a mask and all these measures. And many businesses choose to take their employees' temperature as they walk in. Most, I will say, particularly the larger industries, just ask their employees to do it themselves and, to self-report if they're having a fever before they come into work every day. It is difficult, if not almost impossible, to do that to your clients. And maybe you have a certain business or industry that you feel you can and should, but what most have done is strong signage on the door saying, please do not enter this premises without, if you have a fever or muscle aches or any blah, 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 symptoms of COVID, please maintain good social distancing and please wear a mask, like asking that. And then set up your business in a way that you can't have large groups of people cluttered together. Like you have sort of roping and big X's on the floor where people stand in a line. You have hand sanitizer as they walk in the door. You know, you have things set up in a way that it kind of moves people, that facilitates these measures being taken. Then when it comes to how do you address the customer who, breezes in coughing without a mask, and that's the social science. And I can't tell you there's one way. Obviously, shouting and fighting and those type of things are not helpful. I think maintaining your calm, pointing out that they don't have to come into your business. It's a choice for them to come into your business, that these are what you require. If they don't want to do it, they're welcome to, take their business elsewhere. And that is what most people recommend. I will tell you that's what the big industries are doing is, if, please, it is our rules that you have to be wearing a mask or whatever on our premises. If they refuse, say, then, we invite you to take your business elsewhere. If they absolutely refuse to leave and are being a nuisance, and that's like what you would do if anybody came into your business and started screaming or being violent, you call the police or you call security. It's that behavior. And demonstrating consistency, I think, is the most important. You can't let a few in, but not others. That's where you'll get in trouble. So strong signage, good role modeling with your employees, and then just politely and calmly, this is, it is the rules of this business that you be wearing a mask and distanced on our premises. And if they say no, then say, we invite you to go somewhere else.
A hard conversation for sure.
Yeah.
So we've got about 10 minutes left, so we'll try to get through a couple more questions. Here are some popular ones. What are the stats on people who have ongoing effects such as decreased cardiac, respiratory, or neurological abilities compared to before infection? So I guess that's sort of the
Yeah.
long-term effects of COVID.
Sure. So we're learning. It just hasn't been around long enough for us to even know what the true long-term effects are. Anytime somebody is critically ill in the intensive care unit and requires a ventilator or requires ICU support, they will have long-term effects. If somebody has that bad of a syndrome and they come out and have it, is it because they were on a ventilator and they were critically ill, or is it because they had this particular virus? If they are critically ill from a heart attack, they will have these effects. If they're critically ill from a normal bacterial pneumonia, they will have these effects. So that's what we're waiting to see is, are these effects unique to the virus, or is it just that the effects of the aftermath of being critically ill? We do know that the virus can affect some organs in some cases. It can affect the heart, it can affect the lungs, but we also know that there are cases of other infections like Coxsackie, for instance, that can cause damage and effects to the heart that actually go away over time. That not all of them, but many of them. We know young people with Coxsackie can have terrible heart disease and you just wait it out. And many times you can't wait it out and they're too sick, but other times over a few months to a year or so, it almost completely resolves. So that's what we're going to have to wait and see, is if there are long-term effects specifically due to the virus or if it's just the effects of being ill.
Could you talk a little bit about how long somebody stays contagious? There's a few different questions that kind of get at this, where someone's been tested and stays home, but then they get better and they're not symptomatic anymore. At what point does someone become not contagious?
So the CDC has recently published very good data looking at not necessarily viral replication, but looking at contact tracing and epidemiology, like who actually gets infected from who. And it's robust data. And what it says is, after somebody has been tested positive or from the beginning of symptoms, the general person is infectious for about 7 days. And that's why they made the recommendation that you isolate, which means you're positive and you stay home for 10 days and at least 24 hours from your symptoms resolving. If you do that, then it is safe and your chance of infecting others is virtually nothing. But do not get retested for at least 3 months. And the reason why is we know people who have infected can continue to shed some virus for up to 3 months. If you keep testing them, you might still keep getting positive results. But that virus is not, like I was referring to before, replication competent. It's not capable of infecting others. It's just bits of dead virus that you'll keep picking up in the nose. So once somebody has symptoms, for the vast majority of people, if someone's severely immunosuppressed or other things, it may be longer. But for the vast majority of people, after you have symptoms, within about 7 days, it's virtually nothing. And that's why the CDC gives it a few extra days. Wait till you're 24 hours without symptoms. But 10 days is a very safe number. Once you've gone 10 days from the beginning of symptoms and 24 hours from the last symptom, it's safe to go back. You don't need to be retested to prove you're negative. In fact, you should not be retested.
Okay. Given that we're an audience of chambers and local businesses, here's a question about what suggestions would you give to chambers so we can advocate for businesses and contribute to the local economy while maintaining safety for our members as well as their employees and customers?
Great question. And I would just get back to the 4 basics. It's just continuing to emphasize to all of your businesses the importance of those 4 things: masking, physical distancing, disinfecting high-touch surfaces, and hand washing. And anything you can provide to the businesses you represent to facilitate that. Maybe it's signage for them to put on their doors. Maybe it's even talking points that business owners can have for clients who have questions. Maybe it's talking points for their employees that business owners can explain to their employees and talk it through. Maybe it's providing access to extra masks in case a client walks in and, oh gosh, I forgot my mask, and you can at least provide it to them so they feel welcome into your business rather than rejected. Maybe it's all of those type of things that as a commerce you can help provide to your businesses to facilitate them doing the right thing.
Okay, and then for employees, for our friends, our families, here's a kind of a combination of things about symptoms, and this will probably be our last question, and then maybe perhaps some wrap-up remarks from you, Dr. Rizza. But the one question is the difference between COVID-19 and common cold flu symptoms. But then the other question is, can you speak to the different strains of COVID mentioned when patients have come down with the virus a second time? We've heard some awful stories, and that many more are just tired or barely knew they had it. So it sort of is that idea that you're not feeling well. How do you know what it is and what you should do about it?
Yeah, and there isn't a good answer right now. So it's possible you had SARS-CoV-2 the first time and you were really sick and had high fevers and the flu, and then 4.5 months later you feel kind of yucky. Is that, what do I do? Do I run back and get tested again? At this point, there is no recommendation other than do not get tested within 3 months. So if you happen to get one of those illnesses within 3 months, if you're very sick, go to the doctor and they'll take it from there. If you're just kind of run down and yucky, you're not supposed to get retested for the next 3 months. After 3 months, the door opens again. And if you're feeling kind of yucky, then if it's minor yucky and you just stay home for a day and then you're totally fine and you wait your 24 hours since symptoms are gone and you continue to wear a mask and distance and wash your hands, then that should be safe. If you're yucky enough that you're really staying home for a few days, then after those 3 months are up, I would recommend getting retested.
Okay, thank you. And there are still a number of questions, but we will be following up not only with a copy of this recording to everyone, but we will also prepare a FAQ. Many of the questions, we have resources at mayoclinic.org/COVID-19 or mayoclinichealthsystem.org/COVID-19, where some of these questions are answered. But we will send some of that information to your chamber executive directors. But Dr. Rizza, in the few minutes we have left, do you want to make some closing remarks?
Other than to thank you all for inviting me back again and to thank you for all you're doing to control SARS-CoV-2 virus and COVID-19 syndrome in the state of Minnesota. I know this isn't easy and you have the heaviest lift as you are preparing businesses and opening businesses and interfacing with the public. And so thank you for all that you're doing. I also ask that you be patient with changes and recommendation. We literally have known about this virus for 9 months, which is light speed compared to any other infection we've dealt with in the knowledge we have now, which is great because we're getting a lot of knowledge quickly, but it can also be frustrating because it means we keep changing recommendations. So just stay abreast of those and stay patient with the medical and scientific community as we sometimes do flip and flop a little bit. But again, thank you very much and keep up the great work and stay healthy.
Thank you, Dr. Rizza, for joining us today, and thank all of you who took time out of your afternoon to listen and submit questions and engage in the conversation. We really appreciate your participation, and with that, I think we will wrap up for the session.
Great.
Thank you
Thank you
very
very much.
much.
Thank you.